case just a couple weeks ago with a 3-month-old that was having a little bit, it was mild to moderate respiratory stress, kind of like what the first picture we saw. You know, she was very tachycardic, heart rates were in the 200s, her oxygen saturations were just a little bit low. They're like 91, 92, just a little bit outside of the normal ranges. And you give a bunch of breathing treatments, and you have to put her on a little bit of oxygen to keep it up. And so I didn't think anything was really bad with her, but I did realize that she needed at least some minor observation just based on her age, and sent her in. And it's my supervising physician, which where I work, there's no doctor there. It's only just you for 24 hours. But the supervising physician that signs all my charts for is another hospital. He's actually dual board certified, and he's a pediatric hospitalist at Baptist as well. So it's funny that I actually admitted her to him at another hospital. And he texted me 4 hours later after I transferred her. And he's like, tubing your little kid, and sent me a chest x-ray, and she had a complete whiteout of her right upper lung, and sats were like 83%. So you're talking about a kid that was just a little sick, mild, not bad. 4 hours later was needed to have an artificial airway put on a ventilator, and she was in the hospital for about 2 or 3 weeks. So the younger they are, the less reserve they have, and the more you need to be conservative in your treatment. And I don't know, I always try to say that word, but I mean conservative when I mean don't withhold, don't conserve treatment, but be very, just think the worst is probably going to happen with these kids, and you want to plan for the worst. So these young kids definitely need to be admitted and obviously observed. Okay. Again, any questions over bronchiolitis, bronchitis, or anything like that? No? I mean, they're all pretty straightforward. Okay. Croup. So I heard somebody here talking that they recognized one of my videos as the sound of croup. That's good. You're ahead of the curve, which is great. So croup is a variety of upper respiratory congestions that produce a characteristic cough, inspiratory stridor, and hoarseness. For the purposes of this lecture, we're just going to talk about a spasmodic croup and LTB, which is laryngeotracheal bronchitis. So it's a very upper airway. So we're talking about, at the base of the main stem bronchus and up. There are a lot of other respiratory conditions that are grouped into croup, but we're not going to talk about those, and I don't think they're not on your objectives anyways. Etiology is most common viral infection. We've seen a theme here, with the number one agent being parainfluenza virus type 1, so paraflu, right? Remember that, because you're going to be pimped on it. I promise you. Do you guys know what I mean by pimping? Okay. You want to offend the ladies in here. Not the literal pimping, but just somebody's going to be...
Blair knows.
What's literal pimping? What's that mean?
So parainfluenza, when you ask what the etiology of it, it's paraflu. Most commonly occurs between kids 6 to 36 months of age in the fall and winter months, so croup and RSV go together. It's typically about a 3-day course of illness, so it's pretty quick. Some clinical features: anatomic hallmark is narrowing of the trachea in the subglottic region of the upper airway. So the airway narrowing in edema is the anatomic hallmark of it, the mnemonic area. Signs and symptoms: barky cough, which is also called a seal bark. If you ever see that on a test or on boards, seal bark equals croup. It really doesn't mean anything else. Stridor, so mostly inspiratory stridor, because it's not an obstructive airway disease, so this means it's not a problem in getting air out, it's more of a problem getting air in. It's restrictive, so that's where you have an inspiratory stridor. Stridor is a high-pitched airway sound that we'll listen to here in a little bit. It's very characteristic. Stridor is not necessarily just with croup. You can have a lot of things that cause stridor, foreign body in the airway, subglottic stenosis, a lot of other problems, things that can cause stridor, anaphylactic shock, things like that can cause stridor. But when they talk about stridor in the setting of a pediatric patient, they're most likely meaning croup. Again, congestion, rhinorrhea, fever, and respiratory distress, kind of the same. You know, you'll see the same thing in pulmonology, which is kind of difficult sometimes because they all present with the same symptoms, excuse me. I mean, everybody's like, oh, I'm coughing, I'm congested, I'm runny nose, and they're going to say that with everything from acute bronchitis to upper respiratory infection to pneumonia to croup. I mean, it's all going to be the same. So the key to figuring these things out is you have to look for the very minor, subtle differences in presentation and exam to help figure these things out. Because again, a lot of these are clinical diagnoses. I mean, you're not going to have a blood test that's going to come back and say they have croup. You know, it's going to, you have to use your brain. Helping distinguishing, so we talked about here, distinguishing between croup and other worrisome diagnoses such as epiglottitis, retropharyngeal abscess, so on and so forth. I have a handout in, I think I have a chart in your handout here that kind of goes over this. You know, and it's not the best little chart here, but it does kind of help. I don't know if you guys have gone over epiglottitis or retropharyngeal abscess. I know you've done this if you've done ENT. I'm sure you've probably done both of these as well. You know, fever, fever is just the worst thing in the world as far as symptoms. I mean, just because you don't have a fever doesn't mean you don't have it. Just because you do have a fever doesn't mean you do have it. So, you know, it's on there just to kind of help point you towards fever is typically more of an infectious etiology versus somebody who has upper respiratory stridor because they got a, Lego stuck in their throat versus, you're typically not going to have a fever with that. Barky cough here with croup, not necessarily epiglottitis or retropharyngeal abscess. Difficulty swallowing, not typically yes on these. So you kind of help differentiate between these things, between epiglottitis and retropharyngeal. Don't see this a whole lot. I've seen this once, ever. Why don't you see this a lot?
H influenza, people get vaccinated.
Right, because most people are vaccinated against the pathogens that cause epiglottitis. Definitely see a lot of retropharyngeal abscesses in the emergency department, but this is an ENT, so we won't talk about it. Yeah. Whatever that was. That was cueing me to go to the next slide. Thank you. All right, Wesley Croup score. So I love scores and tables and risk stratification things. These are the most amazing things that you will use in emergency medicine or primary care or whatever. These let you use your brain less because a lot of smarter people than all of us have done the research to develop this scoring criteria so that dumb people like us don't have to use our brains. We can just use these scores here. And there's all sorts of risk stratification scoring systems all out through emergency medicine and all out through other subspecialties. And I would advise you, if you run across them, to not necessarily memorize them, but memorize that there is such a thing called a Wesley Croup score that's going to help you tell you what to do. Like the RSV and the respiratory distress, like I told you, that there's not a lot of, there's not a score to help differentiate between those two for RSV, but there is a Wesley Croup score to help risk stratify patients based on symptoms and exam. It's grouped in mild, moderate, severe, and impending respiratory failure and uses the level of consciousness, presence of cyanosis, stridor, air entry, and retractions as your basis points to develop. And here it is. It's there for your to look at. I'm not going to ask you to memorize this chart. That'd be stupid because I think it's dumb to memorize something that you can just very easily look up. I don't have this memorized. I look it up every time. But as you can see here in the management section, based on your score, it very much tells you what you can and can't do. Right here. So mild, moderate, severe.
You have really good eyes, apparently.
Oh yeah, you can't read it. Yeah.
I can't see it.
Can you see it on your screens on your laptop?
By
If you
Mac,
blow it
I
up.
have 500.
Yeah. I mean, it's just there, you don't have to use this exact one. If you go on Up to Date or Google it, it's gonna be the same Leslie Croup score. But it's just, there to let you know, so, score of less than 2, home treatment, blah, 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 3 to 7, here to here, it helps you, in all these things, a level of consciousness, or da-da-da-da-da, cyanosis, da-da-da. So you add up all these points, come over here, and it tells you what to do. So it's pretty simple. As far as diagnosis, imaging, it's not necessarily needed for diagnosis, but sometimes it's helpful if the diagnosis is in question. If you can't necessarily hear that characteristic barky seal cough, or they don't have Stridor, and you're trying to differentiate between, we can use an X-ray to help figure that out. Pathognomonics, steeple sign, subglottic airway narrowing. Steeple sign, subglottic airway narrowing. We all getting it? Good. Steeple sign, subglottic airway narrowing is pathognomonic for croup. And here it is right here. Can you guys see this pretty well?
Yeah.
So see this normal airway, this trachea here, and then subglottic region, see how it comes in? So tiny, look how small that is. So you're normally breathing through an area that has a cross-sectional diameter of this. Now you're breathing through an area that has a cross-sectional diameter of that. And so, we already talked about the physics of airflow and how decreasing the cross-sectional diameter of a contained space greatly impacts the amount of air you can get in and out of that system. Again, this is even a close one. I mean, you can tell, there's almost nothing here. This is so tight. I had a kid like this the other day that was actually breathing normal and no Stridor. It was the most amazing thing I've ever seen. She had like no airway but no symptoms. It's crazy. But this is what you're going to see on an X-ray. You can get a chest X-ray. We'll show you this because both of these are just, this isn't a chest X-ray, this is a soft tissue of the neck. This is just a normal chest X-ray, but this is a toned down view of the neck here, and you can see it. So you can see it on the chest X-ray or just a soft tissue of the neck. So if you're having some trouble trying to figure out, is this croup, is this pneumonia, is this bronchitis, I don't know, it's kind of fitting all these things. You can just adjust a chest X-ray and it'll help you figure out a lot of stuff for consolidations versus peribronchial cupping versus steeple sign and subglottic airway narrowing. We all good on the radiology of that? This is a board question. This is, a test question on every test you're ever going to take. Steeple sign equals croup. I mean, it's just one of those things that you're just going to have to know and memorize. All right, so we'll look at some videos here to try and help with croup. So here is a croupy cough with some Stridor, and this is kind of just what it sounds like. When you hear it enough, you'll be able to hear it, walking into triage. You can hear them cough once, and you got a diagnosis before you even walk into the room. So a little bit of abdominal breathing here, not too much. Little bit of supraclavicular retractions. So you can see this little intercostal retractions here. So I would say this kid is in probably a mild respiratory distress. They're kind of zooming in on their that is a very mild Stridor, inspiratory Stridor. Here the sternal notch retractions here, and that very, let's listen to it again. That right there. So a lot of this is just a little bit of referred upper airway sounds, and she obviously does have some edema of the upper airway tract that's causing that type breathing, but that's not necessarily stridulous breathing. So there's a word for when you get on rotations and you pimp, there's no such word as stridorous. Don't ever use it. It's stridulous. Something I learned. Anyways, you'll hear at the very end here, you can hear a lot of the air going in, but then all of a sudden you'll hear a very high-pitched sound, kind of like, almost like a whistle, and that is the stride. Let's listen to it again. Right there, you hear that high-pitched sound? That's strider. And again, there were retractions and things like that, so. We need to listen to it. Everything okay? Good. Okay, we'll listen to another one here. Here's a little bit older kid. He's about to die.
Like, who's videoing?
I know, that other kid needs to be in the hospital, too, or at least be in the ER or something, if they hadn't already gotten treatment. So, this is more of a listless type kid, that's just like, you know, maybe they're just sleeping, you know, he's probably obviously just sleeping. If he's been sleeping for, you know, an hour or two, I wouldn't say that's bad. But if you get a kid that looks like this, or an infant that looks like this, that's in the emergency department, and you're like moving them all around and doing a bunch of shit to them, and they're still looking like this isn't a very great looking picture. This would be a very listless, lethargic, toxic appearing kid. So let's listen to the stride on this one. This one's more severe. Again, mild breathing, intercostal retractions here. Not so much supraclavicular here, but you can see going through here. So this one isn't as high pitched as the others, but again, you can definitely see that he's having some difficulty breathing. Yeah, I don't know why they're like, hopefully the ambulance is on the way or something. They're like getting the car ready because it's a fairly sick kid. Okay. And so you'll get to where you just, you know, you just have to hear it more and more, and you'll get to where you can recognize the croupy cough, but hopefully you definitely should be able to recognize and practice the stridor, because that's more of an emergency than anything else. So treatment's here. You know, it's all based around that Wesley Croup score, and it just tells you exactly what to do. It's awesome. A mild croup, Wesley Croup score less than 2, so you treat with cool mist humidifiers. So the cold air will help reduce the edema of that upper airway. Fever reducers, oral fluids, cool air. So a lot of anecdotally things you're going to see. You're going to see these parents that come to the emergency department, and their kid's stone cold normal. Everything looks fine. They're like, I'm telling you, 30 minutes ago, he was at home and he was having that barky cough and trouble breathing, and, you know, sounded like something was caught in his throat, and then came here and he's acting fine. That's because a lot of times these things happen in the fall and winter months, and it's very cold outside, so they take him outside to go from the house to the car, and it's cold in the car, and then from the car to the ER. Just that simple act of breathing in that cold air will decrease the edema in the upper airway and cure them in the more mild cases. And so a lot of times, as far as anticipatory guidance and things we tell the parents to do for the younger kids, you know, if they start to get a little bit more pronounced barky cough or feel like they're having some trouble breathing, is stick their head in the freezer. Open the freezer door, just stick their head right in it and just breathe in that freezing cold air, and it will decrease the amount of swelling. For the more educationally challenged parents, you got to remind them not to put the baby in the freezer or to, you know, leave them in there. You got to make sure you tell them that I'm not kidding. People will do that. Anyway, so this is something you would tell them for the mild Wesley Croup scores. Again, so the mainstay treatment for croup is Decadron, oral steroids. I prefer Decadron, and so does the literature, because based on Decadron's pharmacokinetics, it has a longer half-life because of its molecular size than oral prednisone. The half-life of Decadron is about 3 days, and we talked about the symptomology of croup lasting about 3 days. So you can give a one-time oral dose of Decadron, and it will last them the entire length of their illness, versus if you give them Orapred or prednisone, prednisolone, medications like that have a shorter half-life, you're going to be dosing more often. Those are dosed twice a day for 3 to 4 days, versus a one-time dose in the ER or primary care, urgent care, and you're done. The dose on this is 0.6 milligrams per kilogram, maximum of 10 milligrams. So know this is, this is the mainstay of treatment here. Oral steroids to reduce that inflammation. You can give it oral, IV, or IM. If they're having a young kid who's having trouble taking oral intake, IM and IV are also options. Moderate to severe croup. These are your Wesley Croup scores, higher, 5 or higher. Again, Decadron is the mainstay. We're going to be using that every time. And then another one is nebulized racemic epinephrine. Okay, so that is an epinephrine mixture that is nebulized through a nebulizer and inhaled. It's breathed in. It's the same thing like albuterol, but you're nebulizing epinephrine. The dose is based on not necessarily a milligram, because epinephrine is a very, you're talking about tens of thousands of milligrams or micrograms on the dose. So they just do it by milliliters, 0.05 mils per kg or max of 0.5. If you got a kid that's over 6 months of age or so, just go to the max. Just hit them. If they're so bad, the fact that you need racemic epinephrine, then just hit them with the max. It's a systemic alpha and beta adrenergic agonist. If you guys talk about that at all, and I'm sure you talk about that in anatomy, maybe a little bit of physiology, but it produces a lot of systemic effects as far as relaxation, smooth muscle bronchial tree, through beta-2 receptor activation, and also it has some alpha adrenergic effects, but we don't necessarily care about the blood pressure and heart rate, which is what a lot of those take care of, sort of beta ones as well. The big thing with this is that you must monitor for rebound effects. So you'll get a very bad, highly stridulous kid who's having some respiratory stress, and you'll give them a racemic epinephrine treatment, and they're fine, they're perfect. I mean, it cures them, it takes all their symptoms away. It's the most wonderful drug. But its half-life is only 1 to 2 hours, and then it wears off. And so that's why you must give Decadron with it, so that you get that steroid cooking that'll decrease that inflammation. And you have to keep them in the ER for at least 2 hours. The books in the literature say 3 to 4. That's kind of a long time to keep somebody in the emergency department when you're trying to rotate people in and out. So about 2 hours, I think, is standard of care from a lot of different physicians and pediatricians that I've talked to and worked with. And it happens rarely, but does happen, where after 1 to 2 hours the epinephrine wears off and they go back to either worsening stridulous breathing or still having that upper airway edema. And if that happens, those are the kids that need to come in and be monitored. You can give more than 1 dose of this. We'll let the pharmacologist talk about the dosing profile of it, but you can give more than 1 dose. But if you're talking about giving more than 1 dose of racemic epinephrine to a kid with croup, that kid needs to come into the hospital and be hospitalized. Again, intubation if impending respiratory failure. You're talking about the kid that looked like on the second video that we saw. Again, symptomatic oxygen, fluids, coolness, things like that. All right, any questions over any of that? I know I kind of blew through croup pretty quick, but we're getting caught on time, so I apologize it took a little bit longer.
I know some of these have a really high pitch, but how would one differentiate this from a person who's a really heavy snorer?
Children should not snore ever. So any kid who snores that's under the age of, I think, 10, they'll talk more about obstructive sleep apnea in children, you can get pediatrics. But snoring in children is an abnormal finding all the time. Children should never snore. And adults never. Adults typically don't get croup, so you don't have to worry about somebody who's snoring. And if it's somebody who's a really loud snorer, wake them up. Wake them up, sit them up, get them breathing normally, and if they're still breathing like that, then that's stridor through edema. So snoring is just you have a lot of supraglottic soft tissue that falls and relaxes as you are sleeping, and that's what causes that snoring sound. But whenever you wake up and sit up, people aren't breathing like they're snoring 24 hours a day. So wake them up, sit them up. and see if that goes away. If it's edema that's causing the snoring sound, or the striders breathing, you're having trouble, that won't go away regardless of positional change. So change their position, wake them up, and if it stays, then, and a lot of times you'll elicit that stridorous breathing and croupy cough by just, pissing the kid off. And so I do that sometimes with their parents are like trying to describe what's going on, but he's just kind of chill. I don't know, you mess with them, look in their ears, or do a whole bunch of stuff to just kind of make them mad, and they start crying. And so when they start crying, they're like, hey, and then, kids, they start crying, they go, they stop breathing, they take that huge deep breath whenever they're crying, and so you'll hear that stridorous breathing with that. So kind of mess with them, don't slap them around or anything like that, but you kind of mess with them to get them to cry a little bit, and then that will elicit that stridorous breathing. And that's the difference between, in the Wesley Croup score, when you guys look at it, there is a category on points for stridor with agitation versus stridor at rest. So stridor at rest is much worse. If you're just stridorous breathing while you're sitting there, that's much worse than, when you get agitated, you have to take a huge deep breath or whatever, and you have a little stridor. That's not as bad. So again, with croup, Decadron, and racemic epi. Racemic epi, if they have inspiratory stridor at rest, or a worsening croupy cough, or just based on your Wesley Croup score, it's really good. It takes the thinking out of everything. If you're struggling on whether or not to give somebody racemic, if somebody comes in with croup, it's easy. You give them Decadron on almost every Wesley Croup score. But whether or not to give them racemic epi, that's the difference between seeing a kid for 5 minutes, giving them Decadron, talking to the parents, and sending them out, versus having them stay in the emergency department for up to 2 hours. That's a big choice, because that changes the whole dynamics of the department and everything like that, about how patients move in and out and things like that. So if you're having difficulty deciding on what to do, go back to that Wesley Croup score, and it tells you what to do, and document that in your chart. Document it all the time. Any other questions? Any other questions about anything in general? Not related to croup bronchitis, bronchiolitis?
Would it be smart, like as a preventative measure for croup, with someone like a moderate case, to have, tell them to let the kid breathe in front of a freezer? Just, even if they're not necessarily having that?
Not if they're not.
Not if they're not showing,
Yeah.
okay.
If they're symptomatic, then you can do it.
But
But it wouldn't really,
it's not gonna help them.
no. But if they become symptomatic, then, because if you, there are some caveats to that as well. If you're having them sit in front of them and breathe in, cool, dry air, except from a refrigerator, not a whole lot of moisture in there sometimes, unless you have ice or whatever. You can dry out their airways and things like that, which you can place them at small respiratory compromise that way. But that's one of the things that more of a kind of a trick that you just tell the parents for the more mild croup cases, or the ones you send home.
Yeah.
Just to keep them from coming back to the emergency department, 6 hours later, because it sometimes takes the Decadron about 4 to 5 hours to reach its peak effectiveness. Any other questions, concerns? We all good? All right, what do you guys have next?
Over
Fun.
this.